live stream, July 6, 2022. And this is, of course, together still with Dr. Oybek Rastomov. And today, of course, we will be having IVF cycle planning all about fertilization. So, ladies and gentlemen, this afternoon, definitely if you have questions and comments or messages in the comment section, please do leave it those where the stream live is being broadcasted across LinkedIn, Facebook, Twitter, YouTube, and other social media platforms. And those who are watching right now can also simply message or send us your questions via rustamov.com.au or simply type in your questions by sending a direct message to our official Facebook page. Disclaimer notice as well that different types of patients has different results, and for more accurate diagnosis on your concerns, you may refer and consult with your respective GPs or physicians. Ladies and gentlemen, let's welcome right now fertility specialist and clinical doctor, fertility specialist practicing Adora Fertility Brisbane, Dr. Oybek Rastomov. Good afternoon, Doc.
Good afternoon, Jesse. Thank you. Thanks everyone for joining the live stream and watching the video later on. So today we are covering cycle planning and we will discuss how we decide the method of fertilization for each patient. Okay, so we're on the step 14. We're in the stage of cycle planning. We're planning the cycle for the patients before they actually start IVF treatment cycle. So one of the steps in cycle planning is deciding what method of fertilization to use. We need to individualize each couple's for this decision for each couple. So that decision should include method of fertilization we are going to use and timing of the production of the sperm and the source of the sperm. So let us analyze it by one, which helps us to decide what is the right method for each couple. So in terms of method of fertilization, we have two different methods for insemination of the eggs with the sperm. One is IVF and the second one is ICSI. So, and in order to decide what's actually exactly right method for each couple, we have to have an overall knowledge and understanding of properties of these two different methods. So which means we need to know what's advantage and disadvantage of IVF compared to advantage and disadvantage of ICSI. So in terms of advantage of IVF, and in IVF, what we do is we take eggs, each egg, and leave each egg with hundreds of thousands of sperm. So, and in that process, so among hundreds of thousands of sperm, best ones approach egg first, and they have interaction with the egg. So essentially, the sperm and egg have a signaling mechanisms where they send the signal to each other through their receptors and signaling pathways, and they kind of talk to each other, and egg will select what's actually best sperm, and that lets that sperm to penetrate and fertilize. So that's biological selection. So that is one of the best, most important advantages of the IVF. We think nature knows best. If a patient can have IVF, so then IVF will be the right method for that reason. So the second thing is in IVF, we leave eggs with the sperm in the dish for fertilization overnight. So eggs have surrounding cells we call cumulus cells, which gives nutrition to the eggs. So if you have some eggs which are not quite mature and very close to the maturation, that IVF gives them additional time for maturation. So which is not the case in ICSI, which we'll examine later. So in terms of disadvantages of the IVF is IVF may not be able to overcome sperm abnormalities. So if sperm has abnormalities, then if you do IVF, we can have a much lower success rate in terms of fertilization and overall success. So for those patients, ICSI is the right method, which we will examine. So, and also some patients have anti-sperm antibodies. So, which means eggs may reject the sperm. So usually it is, we cannot tell unless we do the specific test for that. So sometimes we find out that after the fact we do IVF, then we realize actually this couple have anti-sperm antibodies, and because we can see the binding issue. So, and then we need to do ICSI. So this is one of the other disadvantages of IVF, although this problem is not very common. So now if we examine ICSI, an advantage of ICSI is it overcomes a lot of sperm problems, including problem with the motility. Because in ICSI, we take the egg, strip the egg off surrounding cells, examine the egg, and select the sperm and inject directly. So we don't need to rely on motility of the sperm. And also, and the there isn't any issue with binding because we don't need to rely on binding because we're directly injecting the sperm into the egg. So also ICSI is the only option for patients with severe male factor infertility. So and all then third advantage of ICSI is it allows us to examine eggs closely and assess quality of the eggs. For example, in IVF we cannot assess fully because we don't strip off the cells cells surrounding cells and don't look directly into the surface of the egg on IVF. In ICSI, we can do that. We can actually see if there's any significant issues with the quality of the eggs. That helps us to understand the couple's infertility and helps us to make a plan for future. For example, if there's significant issues with the quality of the eggs and we have very low fertilization or low embryo development, then we assume we can factor that in, assume probably it's something to do with the egg quality rather than sperm. So yeah, so that gives us additional information. So and in terms of disadvantage of ICSI is because we manipulate the eggs with the instruments, invariably some eggs can get damaged. So generally damage rate is not very high. It's believed to be generally less than 10%. But still, it can be significant in patients who have a very small number of eggs. So, and the second issue is, again, as we discussed in IVF, the selection of the sperm is biological. Egg actually select the sperm. But here, we select the eggs by visually assessing. We call it morphological selection, which means we look at number of sperm in the dish and pretty much randomly select one of the best sperm available. So although the sperm may look normal from outside, but the sperm may have some quality issues or chromosomal abnormalities, and in a random selection, we may randomly select abnormal sperm. So overall, in terms of selection, of course, IVF is best if sperm quality is normal and if IVF is indicated. So then also there's no time for egg maturation, like we said. And when you do ICSI, after egg pickup, within few hours, you examine the egg and strip off the eggs from surrounding cells. If oocyte is immature and there isn't any chance for that oocyte become mature later on, and you have to discard that oocyte. So so that's another disadvantage. So yeah, so overall, weighing up all these advantages and disadvantages of these two methods, then after reviewing individual couples' fertility, then we decide actually for this couple, IVF is the right treatment, right method, and this couple, ICSI is right method. So, and also there's much simpler way of deciding what is the best fertilization method is just going by overall history and semen analysis result. Generally, if couple are undergoing first IVF cycle and if semen analysis normal, we recommend doing IVF. So if semen analysis abnormal, probably ICSI is the right treatment in most patients. So in patients who need a surgical sperm retrieval, which means if you're taking sperm directly from the testis, then they definitely need ICSI because the sperm we obtain from the testis by aspiration is of not sufficient quantity and maturation, which allows us the fetal insemination with IVF. So definitely they have to have ICSI. And a lot of other patients who have a severe, moderate, even some mild sperm abnormality need ICSI. And patients who have anti-sperm antibodies, certainly the ICSI is right method. And also patients who had IVF previously and had a low fertilization or failed fertilization, then again ICSI is the right method for fertilization. Okay, so just to simply put, if semen analysis is generally normal, then IVF is right method. If abnormal, it's ICSI. In some patients, we actually split into two. We do 50%, for example, eggs will be fertilized with insemination with IVF and 50% ICSI. So generally, that's not very common method. But generally, we do that when we are not entirely sure what is the exactly right method for this couple. For example, if couple underwent number of IVF cycles using both IVF and ICSI, if they had a variable fertilization rate or fertilization with both IVF and ICSI, we're not quite sure. Then we want to give a chance to eggs to select some of the sperm in IVF, and also we don't entirely rely on eggs and do ICSI in the remaining eggs. So we usually call it 50-50 split. So in terms of timing, we can generally fresh sperm is best if it's available, if available. And in some patients, in some couples, we may not be able to use fresh sperm. We may need to use frozen sperm. Usually, we do that if, for example, if partner male patient is not going to be available on the day of egg pickup. For that, they may just need to freeze the sperm so that we can defrost and use on the day, or for medical reasons. In some patients, if they have a severe sperm abnormalities, or if they don't have any sperm, if they did not have any sperm in the past and they stored frozen sperm by doing surgical sperm retrieval, and they may wish to use frozen sperm. So that has to be documented in the plan, and we need to, embryology scientists and patients and whole team should know whether we're using fresh sperm on the day of frozen sperm. And also, we have a third plan, which is a fresh sperm with a frozen sperm backup, which means in patients with extremely low sperm concentration, what can happen is, especially if it's testicular, so their sperm concentrate count can vary around very low end, which means in some samples they may have some sperm, and next sample they may not have any sperm, or they may have very few motile sperm. So for these patients, it will not be possible to predict for sure whether they are going to have a sperm on the day after the egg pickup. For these patients, we can ask them to back up some sperm in storage, and then produce fresh sperm on the day. If we find good quality sperm on the fresh ejaculate, we use that. If not, then without getting couples stressed, we can use a backed up frozen sperm for ICSI. So, and the third is in terms of source. Of course, ejaculated sperm is best. So if partners are available, and if there's a sperm in the sample, then ejaculated sperm will be best. But again, in some couples, surgical sperm retrieval is only option. For example, in patients with azoospermia, which means there's no sperm in the semen, and they have to have a surgical procedure to obtain sperm directly from the testis. So that's called, for example, TISA and TZ. These are the procedures for surgical sperm retrieval. And in some patients, we plan ejaculated sperm on the day and with a surgical backup, which means that in patients with extremely low sperm count, like we said, it's not predictable whether they're going to have a sperm on the day. So they can produce ejaculated sperm on the day of their partner's egg pickup. If we find the sperm and we use that, if there isn't sufficient amount of sperm, then we can do TISA procedure on the day of egg pickup. So typically these patients come fasted, ready for the procedure, provide the sperm. If you find the sperm, all good, then they can start eating, and we cancel the TISA procedure. If you can't find the sperm, then immediately they have a TISA procedure, and so that eggs can be inseminated with the sperm which is retrieved with the TISA. So yeah, there are a number of options in terms of method and timing and source of the sperm when it comes to the fertilization. But most importantly, the specialist and pair couple have to discuss this in detail and make very clear plan what will be the method and what will be the timing and source of the sperm for fertilization, so that the couple do not need to get stressed unnecessarily, because there's always backup plan in place. And if one plan doesn't work, then we'll have got contingency plan already made, and all a team, scientists, nurses, admin, and couple and fertility specialists are aware what is actually the plan for fertilization for this particular patient. So yes, so this is the end of my presentation, JC.
Thank you so much, Doc, for that one. And there you have it, ladies and gentlemen. That was the IVF cycle planning for fertilization. Now we will move on with some questions. Feel free to throw in your questions in our social media pages where the live stream is being broadcasted, or you can message us at rustomov.com.au. Now, Dr. Oybek, here's my first question to you. How do you extract sperm surgically?
Yes, it's a very good question. So, in patients who have azoospermia, which means they don't have a sperm in the semen, but we believe they're producing the male partner is producing sperm, but it's not coming out. So, which means for them we can retrieve sperm directly from the testes. So essentially, there are two different sources of the sperm we can extract from. One is a testis itself, where the production happens. So and also we can extract sperm from epididymis. Epididymis is a storage tank attached to the testis. We can directly extract from epididymis, testis or epididymis. And also there are two different methods for extraction. One is called aspiration, which means with a needle we aspirate without making any cut. And the second is extraction. Extraction means you have to make a cut and open the testis or epididymis and extract the tissue, small piece of testis, small extraction of epididymal tubules. Extract directly. So there are two different sites, testis, epididymis, two different methods, extraction and aspiration. Depending on this, we give different names. For example, TISA means if it ends with A, means aspiration. TZ means if it ends with E, is extraction. TISA, TZ, then MESA, which is epididymal, and aspiration, MESI, which is epididymal extraction. So there are two different methods.
All right. Thank you so much for clarifying that, Doc. Now, here's the next question that I'd like to ask you. How can you tell if the fertilization was successful?
Yeah, good question. So, in terms of fertilization, we assess in two things. One is an individual egg, which is whether this egg is fertilized, and second thing is in the cohort of the eggs, which is how many of those eggs fertilization rate. So fertilization in individual egg we assess next day. Let us say if we did egg pickup today, we do exit today, and next morning we check if that egg is fertilized. So, and it is the same with IVF. We leave eggs with the sperm. Next day, next morning, we check if eggs fertilized. So, fertilized egg, unfertilized egg is got one nucleus. It has got shell, membrane, and inside one nucleus, which has got chromosome of female partner. So then fertilized egg has got one shell and two nucleus. Female and male chromosome, we call 2PN, which is two pronuclear. So that is a way of checking whether egg is fertilized. Second thing we check if the overall fertilization method has been successful in this particular patient, which means we check fertilization rate in that couple. So fertilization rate means how many of mature eggs have fertilized in this cycle. For example, if couple have a 10 mature eggs, we call M2, and if 8 of those eggs fertilized, then fertilization is 80%. That's really good. So, and by assessing that, we can tell if you have achieved good fertilization, poor fertilization, or failed fertilization. So normal fertilization should be more than 65, 70%. So let us say 7 out of 10 eggs should be fertilized. That's normal. If you have a less than 25% fertilization, that is low fertilization. We try and understand why this couple had such a low fertilization. And the failed fertilization means none of the mature eggs fertilized. So this zero fertilization. So assessing all this, we understand individual couples' fertility and make a treatment plan accordingly.
All right, thank you so much, Doc, for clarifying that. Well explained with regard to that question. Now, and there you have it. I think that has been, of course, our IVF cycle planning fertilization. I know some of you has still has some questions. Please do leave those questions and comments on all, of course, the social media platforms where this is being live streamed. Now, Dr. Oybek, please do invite them, everyone, once again, of what they will look forward to for tomorrow.
Yes, so we will continue cycle planning. So tomorrow we will cover embryo transfer. So here we will discuss. So we have to really plan for embryo transfer, whether we are doing fresh transfer or frozen transfer, whether we're going to expect any problems with embryo transfer. So we will discuss this and discuss how we actually plan for embryo transfer procedure before even actually starting IVF cycle. Thanks everyone for joining this live stream, and I wish you a great evening. Thank you.
Thank you so much, Doc. And there you have it for sharing with us all, of course, all about IVF cycle planning, fertilization, and together with Dr. Oybek Rostomov. To everyone, please go ahead, check out all our social media pages and our website, rostomov.com.au, adorfertility.com.au for more information. Disclaimer notice as well that different types of patients has different results. For more accurate diagnosis on your concerns, you may refer and consult with your respective GPs or physicians. Tomorrow, same time, same social media channels for another exciting discussion with Dr. Oybek Rostomov. Thank you, everybody. Enjoy the rest of the day. Thank you, Doc.
Thank you. Thank you. Thanks, Jesse. Thank you.